What was the rationale for the CLOCC trial?
Yeah. Now we know that patients with unresectable metastases are generally treated by systemic chemotherapy. Right? But we also recognize that there's a certain amount of patients which could probably be treated by a combination of radiofrequency plus resection or radiofrequency alone. And we thought that these patients would probably be better off by this combined treatment instead of only systemic treatment. And that was actually the rationale behind this randomized study.
And could you explain how the trial was designed?
Yeah, we selected patients with unresectable liver metastases, and they were defined as unresectable by the multidisciplinary team in each hospital. And then we randomized these patients between either radiofrequency therapy plus systemic treatment versus systemic treatment only.
And what kind of patients were included?
Patients with colorectal liver metastases, which were unresectable, as made by the decision of the MDT team.
What were the main results?
The primary endpoint of the study was a 30 months overall survival rate, and we determined that should be higher than 38% at the design of the study, and that was indeed the case. It was over 60%. And so the primary endpoint was already met, and we presented that at ASCO 2010. We also presented earlier that progression-free survival was significantly different between both arms. Progression-free survival at a median follow-up of 4.5 years was 10 months in the control arm versus 17 months in the experimental arm. But really the issue is whether this progression-free survival difference is also translated into an overall survival difference. And that was the primary reason for this analysis at this stage, where we now have a very long follow-up of 9.7 years.
And could you tell us something about the secondary endpoints?
Secondary endpoints are disease-free survival and overall survival, as well as safety and quality of life. And now we reported on the secondary endpoint, which is the overall survival benefit. And we now demonstrate that in patients treated in the radiofrequency arm, that they show significant benefit in overall survival. In these patients treated with radiofrequency plus systemic therapy, we show a median survival of 45 months versus 40 months in the control arm. And if we look at overall survival after 8 years, we see that only 9% of the patients is alive in the control arm versus 36% of the patients still alive in the experimental arm. So this is really a huge difference.
And how can it be explained that the high 30 months OS rate in the chemotherapy alone group?
We have to realize that we are dealing here with patients who are, for technical reasons, not resectable. So we are not dealing here with patients who have very extensive liver disease. So they really are selected on patients who are, for technical reasons, are not resectable. And that makes that there's, of course, some selection. But, I mean, a lot of things in oncology are due to selection. You better select the patients you really want to have one treatment for. And so also here there is some kind of selection, but I mean that's why we randomized. And in these patients where we thought that probably this radiofrequency ablation was better, right? We randomized them, and then indeed we showed that for these patients we have a significant longer survival.
What can you conclude from all these results?
We can conclude now that if a patient is discussed in an MDT and a patient is considered unresectable, you should go to a second step. And then you should consider, can we still treat these patients with a combination of resection plus radiofrequency, or can we treat him with radiofrequency alone? And if that is not the case, then probably you go to the next step and say, okay, we can't do anything on local treatment for this patient, and then you go to the next step, and that is systemic treatment. So with this study, we really proved that there is a group of patients in between resection and systemic treatment who will really benefit of a combination of local tumor ablation plus or minus resection. And that's really new. And what we think that probably about 20% of the patients with colorectal liver mets will really benefit from this new procedure.